This is Chapter 14, the medical overview. We do not have a Chapter 13 lecture because you guys already did that in the lab when we went through CPR and first aid, and AEDU, excuse me. So many of our patients are either going to be medical or trauma, but there are those unlucky few that end up being both. Trauma emergencies, this is when a force is applied to the body that results in injury. And then a medical emergency is any sort of illness or condition that's caused by a disease. Just because one initially may seem medical or one may seem trauma, it doesn't mean they don't have aspects of both that's actually causing them to have problems. Medical emergencies. There's several different types of medical emergencies, and we'll go into these individually. But just to kind of delve into them a little bit here, respiratory emergencies, patients either have trouble breathing or aren't getting the correct amount of oxygen into the tissue. This can be asthma, emphysema, chronic bronchitis. Cardiovascular emergencies are conditions which affect the circulatory system overall. Heart attacks, congestive heart failure are some examples of that. Neurologic emergencies involve the brain itself. This can be seizures, can be strokes, can be fainting. Remember, that's also known as syncope. Gastrointestinal conditions involve the alimentary canal and all of its accessory organs. So can be appendicitis, diverticulitis, pancreatitis, things along those lines. Endocrine emergencies. Endocrine is most commonly caused by complications that are associated with diabetes, but there are some other issues. Hematologic, these are some sort of injury or illness that occurs because of the blood, sickle cell disease, or blood clotting disorders such as hemophilia. Immunologic emergencies, this is because your body has an over-exaggerated response to a foreign substance, can range from mild sensitivity up to full-out anaphylaxis, which we've already talked about. Toxicologic emergencies is either ingesting some sort of poison or substance abuse that then ends up resulting in another type of emergency. Gynecologic, sorry. This is a special category of medicine that pertains to just the female reproductive organs because they're pretty involved, so they need to have their own doc. Some medical emergencies are also caused by psychological or behavioral problems, and those tend to be the hardest to deal with because you're trying to reason with a patient that is incapable of being logical a lot of the time. There's also urologic emergencies, so that's anything that has to do with your bladder, your kidneys, so kidney stones would be an example of that. Your patient assessment for medical patients is very similar to the trauma, but you end up having an overall different focus. Instead of focusing on finding an injury and fixing it, now all of a sudden we're focusing on the nature of the illness, what's the underlying cause, the symptoms that are associated, and how can we alleviate some of those, as well as their chief complaint. You want to establish an accurate medical history. A lot of this can guide you into a proper diagnosis for your patient. This is more history based, so you don't want to narrow down to, yep, I think it's this, and not ask all of the appropriate questions because that tunnel vision can end up making you go down the wrong path. With a medical patient or a trauma patient, you might have an injury or a sore or something that is visually gruesome, and that can actually distract them from something else that's going on with them. So we don't ever just want to hone in on what we think is the most obvious, because that truly might not be what is the most detrimental to the patient themselves. Assessment may be difficult if you have an uncooperative or hostile patient. Oftentimes, we are seen as authority figures, and some patients don't do well with that. The best thing you can do is maintain calm, professional, non judgmental demeanor, irregardless of what your patient is saying to you. Don't label your patients or display your personal biases against them. And even if you've gone to them 100 different times, there is no such thing as we're not going to come because you cry wolf. That's still our job. We still have a duty to act. And you never know. One of those times might actually be the real time that they need you, and you're never going to know when that is. So we try and treat all of our patients the same, and afford them the same great treatment. Scene safety is like with anything else. You're going to ensure that the scene is safe for you, the crew, patient, and other bystanders. We always, always, always use standard precautions, which means gloves in most situations. Then we're going to determine the number of patients and see if we need additional resources. If we've got several people on a medical call exhibiting similar symptoms, it may be that they've been exposed to a toxic substance, and that can give us more clues as to what's going on. With your nature of illness, this is what will kind of help you determine a path that you need to start exploring. You're going to start looking over signs and symptoms and get your index of suspicion. So this is basically your awareness or concern for a potentially serious underlying and unseen injury or illness. So these are that gut feeling that, hey, something's not right with this patient. That means you have a high index of suspicion. During this time of the scene size up, you'll also want to take spinal immobilization if that's indicated. You can always go ahead and take those precautions and let go later. But it's kind of hard when you don't start off that way and then realize that your patient needs it. You could have caused them harm moving them around at first. Then we're going to go into our primary assessment. The first thing that we do is kind of develop a general impression, do a rapid scan of the patient, not rapid exam. We're not going head to toe. We're just doing a quick scan of them to see if we can identify any life threats. Some of those visual cues that you might come up if they're apparently unconscious, if they're obvious severely bleeding, if they are having extreme difficulty breathing, or just, again, that gut feeling of something's not right here, then that's going to tell you that you need to move quickly. You also then will determine the patient's level of consciousness using that AVPU scale, so alert, verbal, pain, or unresponsive scale. And then we move into the ABCs, airway and breathing being the first of those. So in your conscious patient, you're going to make sure that the airway is open and that they are breathing adequately. Remember, this isn't a are they breathing? It's a are they breathing, and then how are they breathing? You want to check for the rate, the depth, and the quality of their breathing as well. If their airway breathing is at all compromised, you want to go ahead and put on some oxygen right here. Don't wait till you finish the rest of your assessment to go ahead and start treating them with oxygen. If they need it, do it now. For an unconscious patient, make sure that you open their airway using the proper technique. If trauma is suspected, then you're going to go ahead and use that jaw thrust. If there's no trauma suspected, use the head tilt chin lift. And then you need to decide, can they maintain this by themselves? If they cannot, then I'm going to need to use an airway adjunct. Do I think they have a gag reflex? If I do, then we're going to go with the NPA, that little tube up the nose. If I don't think that they have a gag reflex, I can go ahead and try and put in an oral pharyngeal airway. And then I need to decide if I need to ventilate those patients as well. If I can get the tongue up out of the way and they're going to breathe just fine on their own, then you probably don't need to assist them. You can throw some oxygen on and let them breathe themselves. But if not, then you're going to have to assist them. Any patient that is in shock, that has difficulty breathing, or when they have low oxygen saturation readings, so that's an SpO2 less than 94, they need oxygen. Are you going to wait to take an SpO2 before you determine that a patient needs oxygen or not? No. If you get through A and B and determine that there's an issue, just go ahead and put some oxygen on them. We then go into circulation. So we're going to look to see, hey, does my patient have a pulse? And then again, what is the quality? What is the rate? What is the regularity of that pulse? You can look at the patient's skin. Are they pale? Are they cool? And are they clammy? Early indicator of shock, and we're going to need to be a little more aggressive and transport faster. For unconscious patients, you're going to want to start with the carotid artery as your main point for assessing your pulse. That's the one up in your neck. Just because if they're unconscious, we don't want to take the risk of trying to feel down at their radial pulse and screwing around with that too long, and they're truly in cardiac arrest. So it's just quickest to go and check that pulse in the neck, generally on the side closest to you, because if they're not truly unconscious and you're reaching across their neck, they could take that as a threatening move. And now all of a sudden you're wrestling with your patient because they think you just tried to choke them out. A lot of times what I'll do is I'll reach for both of them at the same time. So throwing some fingers up on the neck, throwing some fingers down on that same side wrist, because then I can assess the circulation in 2 points at once, both central and peripheral, to see if they match, to see if one is weaker than the other. Typically, if that radial pulse is weaker, then I know that their blood pressure's down. Their heart's doing good, but that blood isn't getting out to that peripheral pulse area to actually have enough pressure behind it. Once you get through your primary assessment, you should have a good idea of how and when your patient needs to get to the hospital. If they're in serious condition right off the bat, if there's a problem with A, B, or C, they are in serious condition. So we need to transport rapidly. If they're unconscious or have an altered mental status, that's another reason that we would want to transport rapidly. If the patient doesn't meet criteria for rapid transport, A, B, and C are fine, their mental status is fine, you can stay and play rather than loading and going. But go ahead and get a little bit more information on scene, and then you can transport when you've completed your assessment. If the patient's stable, you've got time. If your patient is not doing well, you want to get them to the hospital as quickly as possible, because there's not a whole lot that we're going to do in the field that will definitively treat the patient. We can put a lot of Band-Aids on, we can give them medications which can temporarily relieve their symptoms, make them better, but we can't completely fix the underlying problem with the techniques that we have. So you will need to get them to the hospital sooner rather than later. And we'll continue on in the next one.